Well, good morning, everybody. Welcome to this first edition of this program, Meet Your Qualitist, which is brought to you uh, under the auspices of the Quimpro Foundation, which is under the umbrella of Quimpro Consultants. Uh, 2 years ago, in the month of June, Quimpro Foundation established what is called as the title of Qualitist. Qualitist term, which was coined by Dr. Joseph Juran when he wrote his magnum opus. Well, all of his publications were magnum opuses, but this was among the last one he personally edited, uh, A History of Managing for Quality, where you had authors from all over the world contributing to quality in their part of the world, and he put it all together. Uh, when he was putting that publication together as part of the preface and the text that served as a preamble, he introduced the term qualitist. He said um, that we would have a lot of qualitists in the world today and in the future. And in fact, he said that we are living in the century of productivity, and the next century will be the century of quality. And we thought we were in quality. Now, although this was published in 1995, uh, till 2 years back, nobody really used that term in an official sense. So our very own Dr. Juran, Mr. Suresh Lulla, decided to make that move. He brought in this as a recognition in our country, where an esteemed panel of, I won't use the word judges, but we did have someone who went through qualifications and a combination of experience, skills, etc., and decided to award this title. And they had levels of the qualities. So we created what is called as a level 1, level 2, and level 3 of qualitists. And in the first lot of qualitists that was selected in the country was the name of Dr. Parag Rindani. Talking about the movement of qualitists, just around a month ago, the qualitist movement, we had an interview with our guru, Mr. Suresh Lulla, and we asked him, what are you planning to take this, how are you planning to take this forward? And he made a statement, yes, we have some things in the works, and one of them was choosing the Qualitist of the Month, which came to be known in our correspondence as QOTM or QOM. And then we said, as a part of the celebration of choosing the Qualitist of the Month, we should conduct an interview with a one-on-one interview with a qualitist. And so we decided to go ahead and launch what is called as Meet Your Qualitist. And it's obvious that our first choice was Dr. Parag Rindani. He was our first qualitist of the month, and now he is here in the Meet Your Qualitist. Dr. Parag Rindani, very self-effacing man, a very affable man, and has made it clear he does not want a trumpet to be blown here, whether it is he doing it himself or somebody else doing it for him. So I'm going to keep this brief. He started his career at Workheart Hospitals as a consulting microbiologist, and barring a year of flirtation with Sterling Hospitals, he's been with Workheart Hospitals, and today he holds the position of Vice President and Regional Head at Workheart Hospitals. So our esteemed guest, please welcome Dr. Parag Rindani. We'll also be joined by my co-host, who was a part of Quimpro for the longest time, and today he's on his own, Mr. Anshuman Tiwari. Anshuman and I also go back a long way. We, of course, met at Quimpro. So it's wonderful to meet this Saturday morning. In my part of the country, in my city, the sun has broken through the clouds, and we're having some wonderful sunshine here. I wonder what it is where you are, but that's a good omen for us. So great to see you here, Dr. Parag. If you could
good morning.
Throw some light. Good morning, and could you say a few words before we go ahead and decimate you with the interview?
So good morning, everybody, and good evening to people in other parts of the world. It's a pleasure, it's an honor to be here, and I look forward to interacting with both you, Balaji, as well as Anshuman. I think to set the tone of what we are about to discuss, it's important to understand that as doctors, we are essentially kind of pretty used to being revered as demigods, and well, if you're a cardiac surgeon or a neurosurgeon, probably God. And I think it's very humbling when we have people coming in from other domains and explaining to us that there are mistakes in healthcare, there are errors in healthcare that can be idiot-proofed. There are tools which we can easily use, and as an educated lot of people, I think we are extremely competent to work with these tools. All of us are science graduates, postgraduates. Maths is something that's important to us. We understand how things work in terms of processes. We're all process-driven professionals, and therefore, it's really a bad and late thing in life that quality in healthcare has come to roost of such late years. We should have done this probably 100 years back, when the American Society for Quality was born, when American surgeons decided to work on quality in healthcare. But nonetheless, quality in healthcare is a burning topic in terms of what people do. It's becoming a profession. And I think that Kimpro, in its own very, very massive way, has actually played a huge role in encouraging quality in healthcare along with accreditation bodies of our country. So I think that kind of sets the tone for what we've been doing for the last 15 to 18 years in quality in healthcare. And believe you me, it's been extremely humbling. It's been a huge learning process, a huge learning curve for each one of us. And we bow to people in other industries, the food industry, the steel industry, for all the learnings and all the revenues that you've additionally generated by eliminating cost of poor quality. And I think that's something that it's an ongoing process with healthcare biology. So I think we intend to have a very interesting discussion, and I'll hand it back to you with the questions.
Right. I think that was great, Dr. Parag. We always, at the Qualitech Awards, I remember, I still want to state that Mr. Suresh Lula has always given me, to be either an examiner or a judge in the service sector. And I quite like that, because having spent all my life in manufacturing, we've seen all these tools being applied there. But to see the innovation and how people think differently about these tools and services is always a learning experience. So wonderful to see that you've been doing this for years. So I think let's start with Anshuman. You want to ask the first question?
Yeah, sure. So thanks, Balaji. So Dr. Parag, I know, first of all, once again, welcome and to the first show in this series. Both Balaji and I are very excited to, be in this series, to be able to quiz the qualities that are there, and qualities is a profession that, is all pervasive. It should be all pervasive. So I would like to start with a question where we say, which is quite cliched, how did you get into quality in healthcare? Tell us a little bit about your interest in quality and your journey to being one of the most accomplished qualitists in healthcare. And in healthcare, we know, of course, your journey, but the quality part in healthcare, how did you get into it? Is the question.
So at the very outset, I think Mr. Lulla and both of you have kind of overrated the most accomplished qualitist tag. I think there are people in this country who've done far better, but nonetheless, thanks for the compliment. My journey in healthcare quality probably began way back in 2003 when we, as you know, I work for Wokhart Hospitals. I've done so for the better part of 2 decades now. And Wokhart, with its background in pharmaceuticals, when we launched the hospitals, the chairman of the company, Dr. Korakiwala, was very keen that healthcare should become very quality-driven, process-driven, and that's one of the things that we learned to kind of imbibe in our DNA. Our parent company, Wokhart Limited, was somebody who was very gung-ho on quality of the products that it delivered. We started preparing for our Joint Commission International Accreditation, which is still supposed to be the gold standard of healthcare quality. And we started preparing for this way back in 2003. Now, as laboratorians, we are all used to doing quality assurance, quality control. We all do Levy-Jennings charts, and we look up all these deviations, and we understand SD and all of that. But it was very, very exciting when we learned that we could apply the same to care pathways of bypass surgeries. We could look at this. We could look at outcomes of total knee replacements. So we could look at outcomes of angioplasties. And I'm talking in language which even the non-medicals in this audience should understand. So when we realized that and we understood that we should be able to comfortably apply the Donabedian model of structure, process, outcome, and review within healthcare, we all got excited and we started preparing for our Joint Commission International. I think we at Wokhart were privileged and we learned from one of Dr. Suresh Lulla's early students in healthcare, Dr. Lloyd Nazareth, who is currently located in Bangalore and doing a lot of philanthropic work for Bangalore to combat the pandemic. Dr. Lloyd Nazareth was a driver of quality. He was very passionate, having trained with Mr. Lulla. So I think what should I say? The genetic flow is very clear, from the gurus of healthcare to where we are. The grandfatherly equation, so to speak, through Dr. Lloyd is something that we all imbibed. We understood that there are the backbone of anything related to quality is going to be process. We started working on our process. We also learned that you just can't have something called quality improvement. You've got to focus on the process. And essentially what we're all doing is process improvement. We're also looking at product improvement. And as we went through the Joint Commission International accreditation standards, we kind of broke up the pizza into very, very minute pieces. Everybody got involved. We also then subsequently got training from Harvard for quality in healthcare way back in 2003. And just to kind of put a sort of a timeline in place, we launched national accreditation in our country in 2005, which is exactly when we already finished our accreditation cycle. Wokhart was the first of 2-3, or the second. So Apollo in the press got it by about a month before us. We got it about thereabouts in August or so. So I think that was the primary introduction to quality. And then we kind of got hungry. Our appetite got whetted out, and we did a quality improvement project, which was the first with nursing, infection control. As you know, I was a microbiologist. And we did our first quality improvement project on reduction of ventilator-associated pneumonias, which is a healthcare-associated infection, which is something that we give to our patients as an unwanted gift. And we realized that just by putting things in place, putting processes in place, we were actually able to improve outcomes. This is something which I teach now. I'm passionate about it because we were actually able to improve clinical outcomes. It's not just the turnaround times and the patient satisfaction. We were able to actually improve a patient's life, and which goes very well with today's tagline of Wokhart, which is life wins. We learned the importance of teamwork, and that's something which led us on to do more and more quality improvement projects. At some stage, we started talking with Qualitists across the board. We got the Healthcare Management Award in Asia for this quality improvement project. And I guess that's the introduction. No formal course, no qualification to speak of, but on-the-job learning, and something that we are happy to say that you need to have a mentor like Dr. Lloyd, who was himself mentored by Mr. Lulla. Sure. So it's been fun. It's been fun, Anshuman. I think quality is a good journey. The high is there, the thrill is there, and most importantly, as doctors, we learn to give back to society. We're a poor country, so to speak, and if corporate healthcare and trust hospitals really improve on their quality, we can serve so many more people. I think with that ethos, we all jumped into it and became qualitists in health.
And we are also grateful for that because, obviously quality, healthcare, I often say that healthcare, education, and agriculture are the three fields that we owe debt to. And, quality from any point of view is that, anything that can be bettered is quality. We would, the whole mantra is to kind of be better tomorrow, better today than yesterday, that kind of stuff. And in certainly in healthcare, that is even more applicable. And we are, of course, in a phase of our lives that we are seeing that need every day. So before Balaji comes in with the next question, I just had a reminder for the audience that questions are open. So if you are on LinkedIn, you can post your questions live. We will take it towards the end of this show, but do let your questions come in. I will be curating them. And if you are watching this on YouTube or Twitter, there as well, you can post your questions. Balaji, over to you.
Yeah, that was wonderful, Parag, to hear about your initiation into this world. All of us have our little stories to tell when we speak about how we broke into the world of quality. And for most of us here in our country, and especially those who are in this part of the world, and we are obviously in touch with Mr. Suresh Lulla. So my next question to you actually twofold. Uh, One is, of course, how did you get to meet him personally? You just said that Dr. Lloyd was there, and he was guiding you through your accreditation, and of course teaching you quality in general. But Mr. Suresh Lulla won, and the next question is something I've been wanting to ask you personally, Dr. Parag. Right? I mean, I just want to tell the audience that Dr. Parag and I have, at the Qualitech Awards, we've served as examiners and judges. I just mentioned that, in the service sector, and we sit around the table at the end of the whole thing and evaluate and things like that. And during that evaluation, Dr. Parag, you made a statement, okay, which I wanted to ask you very quickly, but we got so lost in the formalities of closing the program that I never got a chance again. You made a statement saying something like that, and you were one of the head judges, if I remember, and you said, "I'm not a qualitist like you people." And I said, "Why did he just say that? He's a qualitist to the core." So just twofold here. One is, how did you get to meet Mr. Suresh Lulla, and why do you call yourself as a reluctant qualitist? That's what struck me for a moment.
So I think okay. So I'll answer both parts of the question, Balaji. I think we met Mr. Lulla for the first time in the hospital when we were working out a national project. I think Dr. Girdhar Gyani, who is the pioneer of accreditation in healthcare, who was Secretary General of Quality Council of India, had visited us, and we were in a meeting to discuss how can we take quality further. And in 2009, early 2010, we kind of decided, it was decided by Dr. Gyani, not by us, of course, that we need to launch something called where we can demonstrate to people that quality in healthcare is also something that can be worked on. You can apply principles, tools of quality. You can apply all the mechanisms that we talk about, the Kaizen, this, that, everything can be applied to healthcare quality with an end game of improving outcomes. And at some stage, obviously, quality becoming a profit center rather than a cost center. And that's something which we worked out, and it was called the National Demonstration Project 1. It was sponsored by the Quality Council of India under the banner of the National Board for Quality Promotion. 10 hospitals were chosen across the country. And that was the kind of the first time that I heard Mr. Lulla speaking. Thankfully, over the last decade, I've had the privilege of hearing him speak. And to the extent that when I'm talking to my teams, I invariably, at least, when we're doing quality circle meetings, we invariably talk about, it just comes through, the left brain and the right brain, how we should be using not just the tools, but creativity. At the end of the day, we're all here for patient care, so that's how we met Mr. Lulla. He gave us the opening oration for the National Demonstration Project Healthcare 1. We didn't have a second one because of multiple things. And 10 hospitals, NABH accredited across the country, took up two projects each. And the journey was supported by the team of Kimpro, who was there with us. They used to visit our locations every 15 days. And please understand, this is North, East, West, South, all locations across the country. What was very important is that that's when we, so to speak, became the unusual/reluctant qualitist. Because for me, a qualitist is a very haloed kind of a designation. It's somebody who is able to generate money out of cost of poor quality. I don't want to sort of tarnish healthcare and doctors with this whole concept of money. But if you're in a trust hospital and you're saving money, you are able to help more people. If you're in a corporate hospital, you're able to buy better equipment. You're able to have more nurses, more doctors. And at the end of the day, profit is not just the amount of money that you put into your pocket. Profit is also social profit. Profit is also, as I always talk about it, it's the triple bottom line. You're talking about people, planet, and financial profit, the third P. But for me, planet profit is also important. So with all of that, we've been talking a lot now about green quality, which we've also learned with Mr. Lulla. And I think we kind of really hit it off well, not just during this NDP, incidentally, which we got the first prize for our project on discharge process 10 years back, and it still remains a perennial problem in this country with hospitals. But I think I was elated when he invited me and said that, Parag, over the next 5-6 years, we need to set up the Kimpro Awards for healthcare and to start and build up towards that, which I'm very grateful has taken birth. We actually have double-digit numbers of projects now coming in for Kimpro Awards in healthcare, and there are some wonderful, mind-boggling projects. So I think I was invited to give what was then called the inaugural lecture on quality in healthcare by Mr. Lulla in 2011, where I essentially gave them just a case study on how to improve discharge and a clinical case study on how to reduce pneumonias in hospitalized patients. It took us another 5 years to 6 years, to the best of my knowledge, when Jigisha and Mr. Lulla and all of us, including all of you, worked together to kind of really evangelize this concept, and it took birth in the face of Kimpro Awards for healthcare. So that's been the kind of a journey in terms of how we met up with Mr. Suresh Lulla, who is deeply entrenched in his beliefs that quality can do good, who has driven for the last 40 plus 50 years now this whole legacy of Dr. Juran. And for that, I think the nation is eternally grateful. This country has really flourished in the areas where he's managed to lend his expertise. Coming to the unusual qualitist part, I think my essential or the reluctant qualitist part, take about 2 decades back, CEO's entire roles in hospitals was to ensure that there were no unions, that billing was done properly. We didn't have so much insurance. We didn't have so many legal hassles. The Consumer Protection Act was something which was nascent and was just coming up. So CEO's role maybe 20 years back was essentially involved with ensuring that patients are treated and patients go home. 15 years back, when we started NABH, when we all worked together as a country under the tutelage of Dr. Gyani, and we launched NABH, we got this whole focus that, no, now we've got to be looking at patient safety, and that's when I think CEOs started getting more involved. As we all know, quality is something that is driven from the top and should also be a bottoms-up approach. It's a paradigm in itself. I mean, you need everybody involved. I honestly believe that there is, there's an article and people can Google it, which says quality is not a department. In healthcare, especially, it's like the gentleman Sardarji who had to take a half day at Tata Steel to go to the dispensary because of processes, Mr. Lulla. And I think it's like that. At the end of the day, if the nurse on the floor at 2 a.m. in the morning is actually looking at the 2 unique identifiers prior to giving a medication to the patient, thereby idiot-proofing the medication administration process. And if that nurse is cognizant of the fact that if she doesn't do it, it may result in the medication error, which may result in harm to the patient, thereby upholding both the tenets of quality in healthcare especially. One is primum non nocere, do no harm. And the second one is the one that Dr. Lloyd often used to recite to all of us: what is done must be documented, what is not documented is considered not done. So when the nurse at 2 a.m. in the morning, when she doesn't have her colleague nurse who's overseeing her, when she is able to document the identification of the patient that she's done it, she's able to document and put the 10 hours of medication administration in place, I think that's when CEOs have arrived. That's when healthcare quality has arrived to stay. What is most important is that we have come to a concept of WPD. This is a very nasty concept which has been there for the last 10-15 years in some hospitals, not all. That's a concept of wo 5 din. Accreditation 2 दिन का होता है, 2 दिन पहले, 1 दिन बाद सब चंगा भला होता है. Then nurses are transferred back, doctors are put off roles, and at the end of the day, the entire ethos why we invested time and energy in quality because of patient safety is something that just goes away. In the last 5 years, when CEOs have thrown themselves into quality, understanding that it is something that's going to benefit the organization as a whole by improving customer perception, by improving patient safety, by reducing medico legal suits against the hospital, by saving on consumables, medication, by reducing stress to their staff. And I think COVID is something that's also brought all of this in a big way. The government's clamped down on financials, payouts to the hospitals. There is this 80-20 thing, at least in Maharashtra. These are the things that has really brought, healthcare quality into focus. How does one reduce the wastage, the cost of poor quality? How does one use medication which is scarcely available in the country appropriately? How does one vaccinate more people? How does one have a lean process for vaccination? I think everything associated with COVID has put the country under strain. So, to my mind, the reluctant qualitists of today is not just me. Probably I was a little more willing, thanks to Mr. Lulla and Dr. Lloyd's teachings. But I think COVID has made a lot of people focus on quality more than they ever did in the past. I think it takes a natural calamity to really wake people up. And to that end, I think processes have come out from ICMR. The country has started to take care of care pathways. There are set defined protocols. There are clinical task forces which are working on healthcare quality by defining when a medication should be given, when, guidelines have started coming in. So to that end, I think that healthcare quality has really come of age in the last 5 to 7 years. NABH tried very, very hard and it succeeded finally. We actually now have enough recognition to be able to do not just Kimpro awards, but at a higher national platform. We should probably, with Kimpro's expertise, they've also started working with CAHO, which is the consortium of accredited healthcare organizations for healthcare quality. I think we've come a long way. And to that end, I think this reluctant qualitist is very, very happy, sir.
That's nice to hear.
Thanks, doctor. While you were explaining the healthcare process, it was quite interesting to see that if you break it down to a process, and there is a raw material, it is going to a process, and there is a customer at the end of it. Every industry is actually same. I mean, I'm not for a moment saying that medicine or healthcare is an industry, because as you said, we revere it. But if you break it down to a process, everything, there has to be a checklist for things, like you said, nurse at 2 a.m., which is similar to saying that, in the third shift, when the spindle is moving and breakages are there, who's there to actually check? Somebody has to be there, and there is a checklist of 5 things to do. Very similar to those things. So thanks for, I won't say demystify, but also bringing the parallels out that all industries can need quality and do need quality, and if at all, healthcare needs even more. So moving on, since you actually touched upon this topic a little bit, so I'll kind of move into that direction. Healthcare quality is even more in the focus over the last year or so, for reasons everyone knows, and we are not getting to those reasons because everybody else is speaking about all that. So, how is India placed among global peers in healthcare quality? Not necessarily in the last 1 year, but in general, how is India placed among the global peers? I won't say similar nations, but globally large countries. How are we placed?
So I think what's important to note is that all of us talk about it, and we all recognize the fact that India essentially is two Indias. We are two countries within one country. You've got urban India and you've got rural India. Thankfully, when Mr. Modi, our Prime Minister, was the Chief Minister of Gujarat, he recognized that and even took healthcare quality to the primary healthcare center. But that's where it's kind of stagnated and really not caught on. And that's something which the National Rural Health Mission is doing. So to first talk about where we are in terms of rural healthcare quality, I think we have a long way to come. The cadres need training. We need to do a lot more work. electricity availability becomes an issue. So storage of medications, things that we normally talk about in healthcare quality, a lot of this becomes a problem. But apart from that, if I were to work, for example, in an NABH accredited hospital in Mumbai, or I were to probably walk into, a Joint Commission internationally accredited hospital, let's say New York or in Madrid, I don't think there would be essentially so many differences as one would have seen about 10, 20 years ago. And let's break this up into, the actual ranking versus what you see on ground. I think things have tremendously improved thanks to the National Accreditation Board. We've got, everybody's understood the standards. People are still interpreting it differently, but we are now into our fifth and sixth editions as we speak. So we've evolved. We've demystified quality for everybody. We've started monitoring quality. About 15 years back, we always used to look at American and British and European data. Today, we have Indian data. We have Indian outcomes. There are Indian repositories of data. So benchmarking against Indian data is something that's come of age. Take, for example, the COVID outcomes that we're talking about. It's published city-wise. I know for a fact because we have one of the lowest mortality rates in my own hospital. And that's why I know that we're able to benchmark. Earlier, it was all like, kaise batayenge, kya karenge, who's going to share their data? Because everybody was like, why should I give you my infection rate? You're going to squeal about it and badmouth me. Today, it is that understanding is there that healthcare quality is something that helps people. The one thing that needs to probably improve is the entire, while it's already come about, is the entire focus on communication. I think generally we need to be a little bit more open in our communication to patients. We're still not, we still don't really speak about errors in healthcare, iatrogenic issues, healthcare associated infections as openly as foreign countries do. There it's the law. I think Indian healthcare has become far more safer than it was, but we still have a long way to go. I mean, I one thing that comes to my mind is this is something that happened many years ago in a hospital. I will not name the hospital, but as you know, a bulk of our staff nurses across India come from 2 or 3 places. We have a lot of staff nurses that come from Manipur. We have a lot of staff nurses, obviously, that come from Kerala. And, they're respected the world over. They hold positions of power in many hospitals in the West, in the Gulf, in India. And essentially, as a profession, I think that has also evolved. But one thing that I can't help smiling and laughing over is how the communication gap, because as you know, our brethren in the South are a little averse to learning the national language, and that sometimes becomes an issue. So in a hospital in Gujarat, I'll say it, So in a hospital in Gujarat many years ago, we had the staff nurse who had to give an injection to a patient, and he was lying on his back, and she essentially wanted him to turn. And she had to turn on the side, and she would, remove his PJs and sort of give him the shot in the butt. Now, this lady had been told that whenever you have a verb in Hindi, you just say, uske aage jao laga do, to matlab the person will do it. And in Malayalam, and I am sorry for the pronunciation, I don't speak Malayalam, but in Malayalam, you see, you have this thing called marinye kadiku, which means that please turn, or, turn on your side. Now, this nurse, in all her innocence, she was a very good nurse, I'm sure, and she's doing well somewhere and wherever she is in the Gulf, I guess. She just told the patient, mar jao. Now, I think these are the sort of communication gaffes, communication issues that, the patient was livid. And, there's another anecdote which we constantly heard about. There was a nurse in Uttar Pradesh and, so she told the patient, she wanted to tell the patient, go and have a bath now, you don't need to be sponged anymore. And she told the patient, bathroom mein baat karo. So the patient was livid and he's saying, main yahin pe baat karunga. With the diaspora of languages that we are faced up with, and plus the complexities of healthcare that all of us face. In the US and in Europe, it's in the Gulf also, it's very easy to get our doctors to prescribe medications which are generic and things like that. So those are the things where we still lag. That adds to the complexities of healthcare. And I think to that end, we have come up a long way in the last 2 decades. And I'm sure, Anshuman, that we've already come up neck to neck with organizations which have been there 70 years in the reckoning in terms of accreditation and patient safety. So I think a couple of 10 years more, and I think we should be absolutely neck to neck with them. We still have a little way to go.
Sure. Thanks, Doctor. Quick reminder to audience, let the questions keep coming. Quite a few have already come in. And if it matters to you, Doctor, your pronunciation of Malayalam has been approved by Ashok Kumar. In the,
Yeah,
you
that's
did
that's one language. That's one language that I think one really needs to learn in healthcare. It really helps.
It has been approved. You did well. Balaji, over to you.
Yeah, on a lighter note, Anshuman, I hope the person approving is a qualitist. Just kidding.
Yes, absolutely. I verified that.
Okay, no offense meant, but it was just a joke.
Sure.
Yeah, Dr. Parag, I mean, Anshuman just asked you about last year, and these 2 years have been, 2020. I don't know. We thought that was the year, and now it became 2021. And
Yeah.
we're hoping that that this would be the last time we look at things with such fear. I hope all of that goes away. It's been such a telling year, and we've seen the medical profession, respond. They were, of course, doing their job, but for the common man to see bravely, the medical profession go in, and so the word our COVID warriors, and all kinds of terms. In fact, our Prime Minister, not once but twice, had gestures, that why don't you, tali bajao, or the light a lamp or something like that, for our COVID warriors. So it came to that. I just want to say, I made an observation, especially one of my niece's child, and a small little fellow. And normally, when you ask children, what do you want to be when you grow up, and they give you all these fancy answers: an astronaut, I want to be a ninja or something like that. And I was surprised when he said, I want to be a doctor. So I asked him why. Now, this is a 4-year-old kid talking, and I asked him why, and he said, this virus, only the doctors are fighting. And then that was telling. I got goosebumps. In fact, I'm getting goosebumps even now. So I just want to ask you this question. For now, this is going to be finally, medical profession is gaining this. It's a wrong word to use, but glamour. Can I use that term? Very different, in a different way, not in a wrong sense, and sure, getting its due in that sense. So people are going to be getting into this profession. I can see that, and hope the trends continue. We do need doctors. But what would be your words of advice to someone who wants to make healthcare quality as a profession? Healthcare, of course, they have their reasons now, so you don't have to work hard at that. They're going to be there. But healthcare quality. So what would be your the initiation? Would it be the way you did it, or would you do things a little differently and help others?
Okay.
Go on this path. Yeah.
So one thing that needs to happen in our country is that healthcare quality needs to come in as a subject at MBBS as well as at BSc nursing level, physiotherapy, and so on and so forth, so that everybody has at least a little grain of healthcare quality or quality management or reporting in them. Reason being that at the end of the day, the position of healthcare qualitist is a very lone child kind of a position. It requires constant motivation, and therefore it's important that everybody else also gets a little DNA rubbed off onto them. That notwithstanding, two important requirements are something that I would definitely insist that people work on. One is ingrained, the other one can be worked on and can be definitely learned. I think very important, many people just deep dive into healthcare quality on passing their masters in healthcare administration or their MBBS degrees and so on and so forth. I don't think you can really improve things or work on things without knowing how the process works. imagine if you were that you go and try to work on a steel plant on reducing COPQ and improving the product without understanding, what are the issues associated with temperatures and alloys and metals and dyes and casts. Doesn't work. I think first and most important, people need to get domain knowledge. People need to understand how processes work, how that process is the unit, as I always say. When we talk medicine, for us, the unit of the heart is a cardiomyocyte. It's a heart cell. The unit of the kidney is a nephron, which is the kidney cell. And therefore, one must understand that for quality, it is process. Till you don't understand healthcare processes specific to that hospital, probably, till you don't understand the overall architecture of how people in healthcare function, I don't think you should just say, I'm going to become a healthcare quality department ka so-and-so, GM, DGM, jo bhi ho. Very important that you understand healthcare quality. Therefore, you understand first healthcare and you understand quality. Then you try to marry the two. We were lucky to have somebody who welded these two together. They made us understand the process first कि healthcare में करना क्या क्या होता है. उसके बाद हम जाके healthcare quality monitor करने लगे, फिर improve करने लगे. That is one very, very essential tenet of anybody aspiring to become a healthcare quality, understanding each and every process. Understanding that in CSSG, how things get cleansed before they get packed, before being ticked off against a checklist. What are the indicators that are to be used? Understanding what are the correct processes that a nurse should follow. Understand what are the medico-legal laws and regulations affecting a hospital. Understanding what is a fire hazard, understanding hazardous material. You need to really understand everything. Then you try and improve the process. And I think the second thing can be probably worded out in multiple words: tenacity, perseverance, passion, diligence. In Bambaya, we also call it Kida. You really need to have a little bit of, the getting it, as my other mentor, Dr. John Helfrich from Harvard Medical International used to say. He always used to tell me, Parag, you and the VOCA team always gets it. You need to get it. If you don't understand what is the healthcare process, you're not going to be able to improve it. Because, any qualitist who's going to work in healthcare, like any other domain, is going to be up against change management, is going to be up against knowledge management issues. There are going to be constraints of financial things happening. So these are the two things. And I think it's important to spend a few years in healthcare before you decide to become a qualitist. Qualitist is a thankless job in many ways. Yeah, but you can really, really get a lot of things done because you are improving so many things together. So to that end, I would say passion and healthcare knowledge. These are the two things that should drive anybody as they take up healthcare qualitist as a this thing. What would I have done differently? I guess I should have met Mr. Lulla about a decade earlier and probably started working with all of you all, and probably have done a 2-year sabbatical in industry so that I could have learned things that currently today I'm still grasping at and trying to learn. That's the other thing. Healthcare quality is, or any quality journey, it's an endless journey. There is no destination. Your destination is in small milestones. You keep gathering. Many people today just put up a qualification of, I became Lean Six Sigma Black Belt. My question to them always is, projects kitna kiya? ROI dikhao. These are the things which we need to understand, that at the end of the day, a healthcare qualitist is one who's done projects, who's improved healthcare, who's improved processes, and at the end of the day, made patients' lives win. If your patient is not benefiting, you are not a healthcare qualitist. Over to you, Balaji.
Oh, thank you so much. I mean, when you said that your mentor at Harvard Medical said that you people at work hard get it. It reminded me of one of my school teachers who used to teach us the subject of Hindi, and he often said this about poetry. Kavita. He said it cannot be taught; it should be caught. It has to be caught. You either you catch it or you don't. So. Wow, that was telling. And of course, you ended with two of the things that Mr. Suresh Lula has drilled, I think, into our heads. customer. I mean, he's so deliberate in his speech. It's wonderful to hear him say the same thing. You can hear him speak endlessly, but he says the customer is more important and most important, and he says we are selling them process capability. So these are two things that are ingrained and they're flowing in our blood. So, right, thank you so much for these answers. I hand it over to Anshuman. Anshuman,
Sure.
you can just take it up. Yeah.
Yeah, I was looking at quite a few comments that have come in. So quite a few people have heard your journey and interest in healthcare quality, doctor. So, of course, Mr. Lula himself has posted something. I guess one Zahid Kambati, Dr. Pankaj Dhamija, Charles from, I think, looks like Africa, Tosif, quite a few comments. One question I will bring up, which is from Abhishek. He works with HSBC. What is the philosophy for cost of quality in healthcare, or I guess meant cost of poor quality in healthcare sector? How does this impact product or customer in general? I mean, in the healthcare context.
So I think cost of poor quality in healthcare is if you just open your NABH books and if you look at all the outcomes that are to be monitored, each of those outcomes is sitting there as a cost of poor quality / EBITDA adding kind of a phenomenon. Take, for example, a cost of poor quality in terms of falls. A patient falling down, even if you've labeled him properly as a high risk for fall, he has a fall, he suffers injury, he stays in your hospital longer. I think that is the impact which you're trying to save. From the patient's perspective, it's very important that he not have any adverse events related to healthcare, which he should, basically he's not coming for that. वो आपकी तरफ से सौगात है. उसको आप healthcare associated infection देते हो, आप उसको fall देते हो. These are the gifts which we are giving him, which are not required. He didn't ask for that and he's not going to pay for that. So I think that's one. The second thing is, remember at the end of the day, the highest cost of poor quality is loss of life. We cannot afford to have such a high cost of poor quality. We had that probably in the beginning of the pandemic when we didn't understand what we were dealing with. It was a new disease. But once we've aged with that disease, once it's like a good wine, once you've understood what that wine is supposed to taste like, you're supposed to focus on that and improve the cost of poor quality. You're supposed to get rid of it at some stage. I think everything that contributes to cost of poor quality is any negative event, like a healthcare associated infection, a fall, a medication error. These are the things that can improve and impact the cost of overall healthcare in the country. We anyway are labeled as people who charge a lot and so on and so forth. So we can reduce a lot of this through this. So cost of poor quality as a concept is something that we borrowed from industry. What are the bad things that are preventable? What is their cost? And how do you prevent that from going and ending in your customer's bill? All that saving is called cost of poor quality.
No, I think well said. I hope, Abhishek, you had your answer. Another interesting one from Ashok Kumar Kurup, who is a qualitist and also approved your Malayalam. So, what can quality learn from healthcare? Is his question. I think very interesting question. The other way around.
The other way around. Yeah.
So, if you ask me, I think the key thing that quality or other domains, if I may just extrapolate the question, Dr. Kurup, Mr. Kurup, if I think it's Dr. Kurup to the best of my knowledge, I think it is about, but not much actually, but it's still about double proofing, idiot proofing, more of induction that we do for our people when they get on board. Identifying the critical processes, the CTQ as we call them, the critical to quality processes. Because remember, ladies and gentlemen who are listening in today, critical to quality in healthcare has two connotations. One, something that's critical to the process. And then there is always the larger assumption that you're also talking about critical to patient care and patient life. For example, if you look at certain critical to quality things that we have highlighted in all accreditation books, you're talking about lookalike, sound-alike drugs. You're talking about concentrated electrolytes. Now, these are all things that probably quality as a concept can learn. What are the things that can cause your shop floor to stop? Have we idiot-proofed that? Have we used the principles of Pokayoke onto that? Have we put in enough checks and balances to see that the stop button on the conveyor belt never gets pushed? Have we disenabled? I mean, have we, sort of stopped the button from getting pushed inadvertently? So, like for example, in every hospital today, you always have UPS systems on the critical equipments. So I think that's something which quality as a whole can learn from healthcare, how to really idiot-proof the critical processes related to medication and related to patient safety. Dr. Kurup.
Yeah,
Yeah.
yeah, no, I think well articulated. While you were talking about this, doctor, I got reminded of a fantastic book which I may recommend, and you will know Dr. Atul Gawande, world-renowned doctor in this field. He's written a book called Checklist, the Checklist
Manifesto.
Manifesto,
Yes.
and even though from a medical profession point of view, he started off the book from a medical point of view, but the book is full of every other profession other than medical. And I still
Yes.
believe the checklist is the most important management tool that anybody can use in any profession. You have a bad day, make a list of things to do, get going. The day turns out to be, and in a hospital, any day can be bad, because of just the context.
Anshuman, I'll just butt in there with a little bit of learning that we've had over the last 60, 70 odd assessments and probably training over maybe 500 people in healthcare quality with NABH. One of the things that we've also found is that while the checklist is something that is a positive tool, should be used well, we've often found a lot of fabrication happening on checklists. So I think it's like any tool, it's a double-edged sword. As my colleague Dr. Clive Fernandez says, it's very important to validate the process to see that it's actually happening. He's a big proponent of validation of data, of validation of whatever tools you're using. So I think it's a double-edged sword. So while I do believe in checklists, the moment I see a dirty toilet at 11:02 a.m. Where the checklist just says it's been clean at 11 a.m., I'm a little circumspect. So I think it's important to constantly remind yourself that not everybody is as honest as you think they are, and constantly work at validation jointly with empowering people.
Oh,
Sorry for that,
no,
Bachchan.
no,
Yeah,
that struggle is totally real. Integrity is a struggle that all of us have to deal with.
absolutely, absolutely.
There is one more question which I think you have partially answered, but I'll still bring it up. Dr. Amish Patak, how helpful will be introducing concept of quality care curriculum in medical, paramedical education? I think you answered that already. So would that help in imbibing? I think this is
Yeah,
answered.
yeah. I think Amish, as an ex-Wokhadian, will also vouch for the fact that healthcare quality. So the other thing, while we wait for the government to move on the curriculum part, what most corporate hospitals have done is everybody's trained people through NABH, and I think it puts a lot of focus. So right from Dr. Gyani being there as the Secretary General, there is an initiative lying with the Ministry of Health and Family Welfare to include this in the curriculum in the second year. So hopefully, I think my colleague from Amrita, Dr. Singh, has been working on that jointly with the government, and we should be able to get through some of that soon.
Sure. Quite a few other comments coming in. Twinkle Gupta, Ujjwal Chakravarti, Zahid again. Thank you very much for your comments. I'll bring in Dr. Nishan Nair. Again, congratulating you on journey. Interesting question from Shrutin Shetty. I'll bring it up. How does the future of Indian healthcare look from becoming more accessible and affordable? Will it continue to be a public plus private mix, or would a stronger public healthcare model be needed? Quite loaded, but a brief answer if you can.
Shrutin, hi, and thank you very much for that very important question. My personal views, this has nothing to do with the company I work for. I personally think that healthcare will become more accessible, especially with digitization coming in. Affordable, yes, provided the industry is treated like an industry and gets the SOPs that most other industries get, like cheaper electricity and so on and so forth. I think CII and other organizations are fighting for that. It will always remain a public-private kind of a thing. I don't think that we will ever have a standalone government kind of an entity. A stronger public healthcare model is needed, and we have seen it evolving in the last 2 decades. Believe you me, if you've been to a private hospital and you've been to a primary healthcare center, things have improved tremendously. Government hospitals today look just as clean, just as nice as private hospitals. There is a yojana going on with the government of India called the Kaya Kalp, which is really bringing private public hospitals to much better levels. And believe you me when I tell you that public healthcare doctors and nurses are at par with anybody anywhere in the world. So to that end, yes, it's needed, and I think we're already moving to that direction. I think sometimes as Indians we tend to poo-poo everything, but I think we've really made great strides in the last couple of decades in Indian healthcare. Anshuman.
Sure. Yeah, last few questions because we are almost on time and we would like to release you. And obviously, your profession needs you more than us. But I think you will be pleased to see this comment. If you remember Charles,
Of course.
your classmate, so he's essentially saying hi. Thank you,
Hi,
Charles, for
Charles.
joining.
Yeah.
And Rajkumar Bansal has also asked a similar question: why is quality healthcare and affordability inversely proportional? So I think we just answered that broadly.
Yes.
Dr. Nishant Jaiswal has asked a few questions. I picked one from them. Why QCI or other Indian organizations develop platform to provide online internship for students who can't afford to pay internship fees? Students are struggling to get right practical knowledge. Again, I think slightly beyond the scope of this discussion, but
Absolutely. But I'll nonetheless give you a cryptic answer. I think QCI, the website is there and you can definitely write. The Secretary General is a very pleasant gentleman, very work-oriented. I'm sure he'll respond to this question. And I think the second thing related to internships, to the best of my knowledge, I didn't even know that there was an internship fee. But then again, I'm kind of 2.5 decades behind you all. I did my medicine way back in 1995, so let's just not go there. I think what's very important is that QCI has other things to do. We do have the ministries working with medical education, and they're doing a stellar job. We have the NMC now, and it's really working well, So I think we'll improve definitely.
Sure. I think there are still quite a few questions coming in, but I think keeping your time in mind, sir, we will call it today. The good part is that many questions are coming on LinkedIn. So whenever you do get time,
I will respond, sir.
Or I will, Balaji and I will try and respond. There are few questions on YouTube, which I will forward to yours.
Sure. It will be a pleasure to respond to each one of those queries, Anshuman.
Yeah. So the good part in these kind of conversations is that they stay on the both the channels, and now today's is on Twitter as well. So it will stay, and we will appreciate that whenever you can. Some of the questions are a little bit more healthcare oriented and may need your answer than Balaji and my imposter answer. So with that, we on behalf of Kimpro Foundation and Mr. Lula and the team and both Balaji and we would like to thank you. This has been a different show for us. We had to prepare a little bit because a visit to the doctor is not always pleasant, but this one was.
Well, thank you very much, and I'd like to take a half a minute to just thank Mr. Suresh Lulla, Dr. Shakuntala Lulla, Jigisha, who's kind of been the pioneering spirit behind Kimpro Foundation, as well as all the Qualitech awards that we've had the privilege of working with. And of course, Anshuman and Balaji, thank you very much for such a warm and a very result-oriented discussion. I think we managed to clear up some things for people, and I hope that we've been able to do something to change the perception of the healthcare qualities as well. Do well, and I'm sure we should be seeing and taking healthcare quality to the next level. Thank you.
Yeah, and I hope we do meet again in person.
Yes.
For the Qualitech Awards.
Yes, we're okay with Wellinkar as well. So the President Hotel did cut a little bit more ice in that sense. Anyway, that's neither here nor there.
Yeah, so in the last half a minute, I'll quickly some basic announcement that the recording of the show will be on both LinkedIn as well as YouTube and Twitter on my handle. So easy to find. I will post it on Kimpro Foundation and Kimpro Consultant handles as well. And snippets of this will also be available. Those who are audiophiles or want to listen only to our audio, though I think Dr. Rindani's smiling face was enough incentive for you to see video. But if you do enjoy audio, it will also be available as a podcast later this week. So with that, thank you very much. And we will end the show now. Thanks a lot. Bye-bye.
Thank you.